Hello, this is Cindy. Today we're going to talk about Chapter 1, which is really just an overview of the Introduction to Clinical Coding. It's really important that you understand this information that's on this slide. It's also in your textbook. You will see test questions about it because it is what is involved in reimbursement in our country for how we get reimbursed our medical care. ICD-10-CM, as you can see, is used to report diagnoses in any setting, physician office, hospital outpatient, hospital inpatient, and that would include ambulatory surgery. ICD-10 is the code set that is the diagnosis that explains why a patient is seeking care. So every procedure code has to have a diagnosis code that provides medical necessity for the procedure. So a claim for a CPT code must have at least one ICD-10-CM code with it. And then the outpatient and inpatient breaks out the way you see it here. It's really important that you know this. The way we teach these codes in our school, the diagnosis coding is HIT241, CPT is 241, and HIT 231 is the PCS. Let me say that again. In our school, ICD-10-CM is taught in HIT 22221. ICD-10 PCS is taught in HIT 231, and CPT is taught in HIT 241. We don't teach HIT-PICS to level 2 HIT-PICS as a separate book because it's so rarely you as a coder are going to be selecting those codes. They are usually hard-coded, meaning they are set up in the reimbursement system that someone just pushes a button and that code gets assigned whenever you're looking at prosthetics or specific services that are not covered in the CPT book. Things you need to know about CPT: it is published by the American Medical Association and updated annually, and all these changes are effective January 1st of each year. You may recall from ICD-10-CM that the ICD codes are updated October 1st of every year. The CPT codebook has 3 categories. Category 1 has 6 main sections. The majority of our CPT codes are in the surgery section, but there's also categories 2 and 3 and the modifiers. Those are considered supplementary. Category 2 codes are used in performance assessment and quality improvement. Even though they're used primarily to track quality improvement activities, some payers actually require them, so it may be that you would be assigning them on a claim. Example given in the textbook is that a specific payer might require that the body mass index is reported whenever you're submitting a CPT code for any nutritional therapy. So you really have to know your payers and know what their requirements are. Category 3 codes include temporary codes that represent emerging medical technologies. These are things that have not been approved by the FDA yet, so they don't have a CPT code, but for good reason, it wants to be tracked who's using them, and especially in research. Modifiers we'll study a lot more in Chapter 3, but these are used to report additional information about any unusual circumstances. It doesn't change the basic definition of a CPT code, but it does. It gives information about other things that happened while that procedure was being performed. Sometimes HIT-PICS gets confusing because CPT is really HIT-PICS level 1. We just don't call it that. We call it CPT. And HIT-PICS level 2 we call HIT-PICS for whatever reason. But what's the important thing for you to remember is that 2 different entities developed these code sets. AMA developed and maintained CPT, and CMS developed and maintains HIT-PICS. And for that reason, if CMS disagrees with anything in the CPT codes, they can't change the CPT codes. AMA can only change CPT codes. So what CMS would do then is establish a guideline or a rule or something that for a Medicare patient they're going to do this, this, and this. So even though they can't control one another's code sets, they do control reimbursement by having guidelines that people have to follow to get paid. This is just reiterating. HCPCS Level 1 is CPT. Level 2 is also called the national codes. And all insurance companies use the HCPCS codes, not just CMS, even though CMS developed them. Medicare, Medicaid, and the private insurers use HCPCS codes and modifiers in the claims processing. And claims, CMS 1500 are used for physician office, for the physician's payment, and CMS 1450, also known as the UB04, for hospital inpatient and outpatient services. There are good examples in your textbook of what these claims forms looks like, so you can tell that. NCDs and LCDs are national and local coverage determinations. This comes into play because Medicare policies include two types of coverage. You have your national coverage and your local coverage. There are contracts between CMS and private insurance companies that are known as carriers. There's also contracts with intermediaries and with contractors who actually process the Medicare claims in local regions. I believe the processor for Medicare in Colorado is Novitas. I'm not positive about that, but I'm pretty sure that's right. I'm not quite at Medicare yet, so I don't know for sure, but I think that's right. And the only other thing I would say about that is that in general, the national coverage determinations are what's followed, and the only time a local comes up is when there isn't a national coverage determination, and so then the insurance companies might have a local coverage determination. That's short and sweet for this Chapter 1. It's really just an overview of the coding systems that are required under the law. That would be the Medicare law, as well as HIPAA requires that we use these code sets the way that I mentioned earlier. If you have any other questions about Chapter 1, let me know, and we will be doing Chapter 2 very soon.